a little late. I don't know where everybody else is. Today we're supposed to be talking about pleural disorders. This is also another very broad area of respiratory medicine. So this will basically be an introduction, and hopefully you can then pick it up from there and ensure that you are learning more about I don't know what this is working. So, of course, during your basic preclinical training, you must have gone into detail about the structure and function of the pleura, and therefore we will not be covering those aspects in detail today. You are encouraged to review the material that is related to those basic aspects of the pleural structure and function, because they form an important basis for you and your understanding of various disorders of the pleura. So, of course, the other important thing is to be very clear about the surface anatomy of the parietal or pleura. So this is the blue line here represents the surface anatomy of the parietal pleura. Superiorly, obviously, the understanding that it extends above the clavicle in the way in which you can see, and inferiorly, that it is extends to the ninth rib peripherally. The recesses of the pleura inferiorly go beyond the margins of the lungs. So that's also another very important point for you to understand, so that when, number one, this is important in terms of pleural procedures, but also when you're looking out for pleural structural change, important information. So that is anteriorly, obviously, and this is posteriorly, also depicting the spinous processes and the relationship between the margins of the lung and the extent of the pleural, the parietal pleura. So very clearly demonstrated here. Laterally,
give us a reason to drink.
Someone needs to. This is now.
Sorry for the interruption. Please.
Yeah, so this is on the lateral aspect, also very important information, the extent of the pleura on when you look at at from the lateral aspect. As I said, we will not have opportunity to go through the details of the functioning of the pleura and the pleural space. I encourage you to review this information with the previous sessions that you had in embryology, anatomy, and also physiology. So when we look at pleural disease, this is a basic classification. Anytime you see pleural disease, these are some of the things you need to think about. Is what you are dealing with congenital or genetic? More often than not, we don't see congenital genetic diseases in adulthood. These would generally be seen in children, but occasionally, you could find congenital origin. Most of the diseases that you come across that involve the pleura will be inflammatory or immunological in origin. And it is important that you differentiate between those that are infectious or of infectious origin and those that are of non-infectious origin, because obviously the approaches are very different. So, so the infectious ones, you would have pleurisy. These are largely, viral in etiology. You would have parapneumonic effusion. So these are patients who have had a pneumonia. We discussed pneumonia previously, and you will recall that we said that parapneumonic effusions are one of the complications of community-acquired pneumonia, hospital-acquired pneumonia, ventilator-acquired pneumonia, and so on. And then obviously pleurisy, TB pleurisy due to TB. And one important infectious cause of pleural disease that is missing here is hemothorax. So Pneumothorax is also an important cause of infectious cause of the pleural disease. Non-infectious disease will largely be diseases related to connective tissue diseases and such, as well as drugs. The most important being rheumatoid arthritis, SLE, sarcoidosis. Those will be really the most important within our setting. Then neoplastic disease can be primary, so primary pleural disease like mesothelioma, or secondary, and these most important would be those related to breast cancer, CA lung, and also from malignancies from more distant structures like carcinoma of the stomach, pancreatic CA, and so on and so forth. Hemodynamic disturbances, and important here will be heart failure, pericardial effusion, pulmonary embolism, and hypoalbuminemia as a cause of pleural effusion. Other causes will be things like spontaneous pneumothorax, chylothorax, and those that are related to trauma. You can have a pleural disease as a complication of very severe hypothyroidism, and that's what we refer to as myxedema. So pleurisy is chest pain due to inflammation of the pleural surfaces. The pain originates from the pleura. The commonest causes are related to infection, neoplasm, inflammation, or metabolic disorders. So infection, viral, bacterial, tuberculosis and parapneumonic effusions. Neoplasms often secondary, but can be on rare occasions be primary. Inflammation, we've already mentioned rheumatoid arthritis and SLE, and then metabolic conditions like in uremia, toxins, especially drugs, and then cardiovascular disease as occurs in myocardial infarction, pericarditis, and pulmonary embolism, and also post open heart surgery. You can have a pleural effusion, and then other causes like sickle cell disease and pancreatitis. It is important to remember that you can actually have pleurisy, pleural effusion, and pleuritic chest pain as a result of drugs. And so taking a good history when patients present with the pleural pain is important. And some of the commoner agents would be cardiovascular agents like amiodarone, bromocriptine, fluid pleural effusion with eosinophilia, as you get with the use of nitrofurantoin, which you know is fairly commonly used. Valproic acid is an agent we use for epilepsy, and isotretinoin, propyl uracil, which you know is used in thyroid disease. Sclerotherapeutic agents, the ones that we use for example, when you want to application of esophageal varices, and that can, following sclerotherapy, you can have a pleural effusion as a complication of the use of the sclerotherapeutic agents. Chemotherapeutic agents, most of those are in common use in our setting: pleomycin, mitomycin, procarbazine, methotrexate, cyclophosphamide, and docetaxel. And one of the huge challenges would be when you have a pleural effusion due to chemotherapeutic agents, and that can create confusion as to whether the pleural effusion is due to the malignancy itself or it is due to the chemotherapeutic agent. So a reasonably difficult presentation. But always remember that, yes, the pleural effusion you see could be due to the agents that are being used for treatment of the primary cancer. Other agents commonly used that can give you a pleural pain include acyclovir, clozapine. You run all the way down to simvastatin, which is an cholesterol-lowering agent that is used fairly commonly, itraconazole and fungo, and IV immunoglobulin, which is also fairly commonly used. Usually the pain would present, the chest pain will be intensified by a deep inspiration and movement, so that the patient can avoid the pain. They have shallow breathing, which gives a sensation of breathlessness, and on examination you may have a pleural friction around. The differential diagnosis would be rib fractures. Obviously, there would be evidence of either trauma, and you can also have spontaneous rib fractures in the cases of the metastatic disease to the ribs, local muscle pain, costochondritis, and pericarditis. So those are the things that you need to think about when patients present with pleurisy. Investigation, chest X-ray may be normal. In conditions like pulmonary embolism, viral pleurisy, serositis as a result, for example, SLE and rheumatoid arthritis, uremia, sickle cell crisis, and Dressler syndrome, which is the pleural effusion following, open heart surgery. If the X-ray is abnormal, what you will usually see is a pleural effusion, obviously, or the underlying parenchymal disease that is responsible for the pleural effusion. And in rare occasions, you may see, pleural thickening. The treatment is symptomatic. You want to give adequate analgesia, and where you have an underlying cause that is known, then you offer specific therapy for the underlying cause. So pleural effusion is an abnormal accumulation of fluid in the pleural space. There is a small amount of fluid, up to 10 ml in just a normal, but once it accumulates, then we consider that abnormal, and that's what is referred to as a pleural effusion. It's detected radiologically when you have at least 200 ml of fluid, and clinically, by clinical examination, it's more than 500 ml. So really, by the time you are identifying a pleural effusion by clinical means, that's a substantial amount of fluid, 500 ml, and by radiology, 200 ml. So as we've seen, the minimal amount of fluid that can be seen on chest film is 200 ml. And if you want to do thoracentesis, you need a margin of at least 1 centimeter or 10 millimeters on the lateral decubitus view. So what are the causes of pleural effusion? This is a table from a global view, and would be different if we were looking at a local view, a Kenyan view. So from a global view, the commonest cause of pleural effusion will be congestive heart failure, pneumonia, malignancy, pulmonary embolism, viral disease, liver disease with ascites, GI disease, for example, pancreatitis, collagen vascular disease, tuberculosis, asbestosis, and mesothelioma. So this is a global view of the causes of pleural effusion. In our setup, then TB will be much more prominent. What are the pathogenic mechanisms for the causation of pleural effusion? The first thing is really altered permeability of the pleural membranes, reduced intravascular oncotic pressure, as you would have in severe liver disease, and protein wasting renal disease like the nephrotic syndrome, increased pleural fluid oncotic pressure, as you would occur when you have intrapleural inflammation, increased intrapleural pressure, increased hydrostatic pressure in pleural capillaries, and this will be the mechanism that is related to pulmonary embolism and heart failure, lymphatic obstruction that often would be due to malignancies, and pulmonary edema. The pathophysiology of pleural effusion is related to restriction of ventilation, and the more the amount of fluid, the greater the restriction, and also if you have rapid accumulation of fluid, then the ventilatory defect, the restrictive ventilatory defect is going to be much more pronounced. Usually you have minimal hypoxemia in mild to moderate effusions, which really tells you that by the time you are having significant hypoxemia and with an underlying cause of pleural effusion, then that's a really huge pleural effusion, which should be relieved as quickly as possible. You would have a hemodynamic compromise in cases of large pleural effusion because of reduced venous return to the right side of the heart, contributing to reduced cardiac output, both from the right side and also from the left side, from the left ventricle. So in terms of classification, the basis, the commonest basis we use is on the physical-chemical characteristics of the fluid. It can be serous, as what we refer to as hydrothorax. Could be blood. We refer to that as hemothorax. Lipids, which is chylothorax, and pus, which is an empyema or pyothorax. So if your fluid is serous, it can be both. It can be either a transudate or an exudate, and here we use something called the Light's criteria to determine which is which. So what you have on your left are the characteristics of a transudate, or and what you have on the right is what the criteria that makes a fluid an exudate. So if you look at the pleural to serum protein level ratio, this is a ratio. So you will take your pleural fluid and get your total protein, and also get total protein in serum. Get that ratio. If that ratio is less than 0.5, then that is a transudate. If it is more than 0.5, that's an exudate. Similarly, you take your pleural fluid and do LDH and a serum LDH, and if the ratio is less than 0.6, that is a transudate, and if it's above 0.6, that's an exudate. The other thing that you could do is just do a straightforward pleural LDH, and if it is less than 2/3 of the upper limit for the serum level, that is a transudate. If it is more than 2/3 of the upper limit of the serum level, that is an exudate. So this is how we differentiate between a transudative and exudative pleural effusions. So that's the Lights. It's referred to as a Lights criteria, and what is indicated here is exactly what I have told you. So so the differentiation between exudate and transudate is very important. The common causes of exudative effusions include infections, pulmonary embolism, abdominal disease, collagen vascular disease, post-cardiac surgery or injury, and post-coronary bypass surgery or grafting, and asbestosis. If your picture is more mixed, so this is a situation where you can either get a transudate or an exudate. This would include hypothyroidism, pulmonary embolism, and trapped, what is referred to as trapped lung. Transudative effusions are largely due to hemodynamic, are hemodynamic in origin. So this would include congestive heart failure, constrictive pericarditis, superior vena cava obstruction, hypoalbuminemic states like in severe chronic liver disease, protein wasting states like nephrotic syndrome, ascites, and peritoneal dialysis. So those will be some of the causes of transudative effusions. How do we make a diagnosis of pleural effusion? Obviously, you want to start with a good history, and where you're looking at respiratory complaints, and as you take your history, in cases where a pleural effusion is suspected, you are also looking for likely underlying causes of the disease that is giving you the pleural effusion. So what is important is that a pleural effusion is not a diagnosis on its own. You always have to look for why is there a pleural effusion. So as you take your history, you want to be looking for likely causes of the pleural effusion. So once you examine the patient, the findings will depend largely on the amount of fluid in the pleura, the amount of pleural effusion. So you may or may not have tracheal deviation, reduced chest expansion on the affected side, stony dullness to percussion, decreased fremiters, absent or markedly reduced breath sounds, and reduced ergophony. So those will be the signs of pleural effusion on examination. So the evaluation would include chest ultrasonography, chest radiography, thoracentesis, video-assisted thoracic surgery or thoracoscopy, and thoracotomy. So this is an example of an ultrasound image demonstrating pleural fluid, where you can clearly see the lung, and then this area, the dark area representing a fluid. This very this structure here is a rib, right? And over here, this must be a subcutaneous tissue together with the costal intercostal muscles or chest wall muscle. Okay, so a chest X-ray a chest imaging, a chest ultrasound is very useful, a modality for diagnosis of pleural effusion, and we also use it for intervention. So imaging guided intervention, or when you want to aspirate the fluid for whatever reason, you want to fix a chest tube. We now encourage that is done under ultrasound guidance. So this is another example of a chest image, a chest ultrasonography that shows here you can appreciate the diaphragm. Obviously, this looks like a lung tissue below, liver tissue below the diaphragm, and then that is lung, and a huge amount of fluid here. This must be on the right side. This is on the left, where you can appreciate the diaphragm, spleen, a huge amount of fluid, and the collapsed lung due to the fluid. This is an example of a chest radiograph. Usually when I give this class in the lecture, I encourage that somebody comes forward and it shows us the difference between the two images. What you want to appreciate is the very clean costal cardiophrenic, costophrenic, sharp costophrenic ankles here, all right? And as you can see on the image on your right, there is a blunting of the costophrenic recess on the right side, and also what we call a meniscus picture, which is a sign of pleural effusion on the left side. On the right side here, the costal the cost of phrenic recess here is quite clean. Okay, so that's this very small amount, but it's important you don't miss it. This is very obvious. Obviously, the cost of phrenic angle here is completely obliterated because of this fluid here on, and this is now on the left side. On your lateral images, you are able to appreciate that there is no fluid on the image on your left, but you should be able to appreciate that fluid here, and also there is fluid on the posterior recess of the pleura there. This is the lateral decubitus image. Okay, you should be able to appreciate that this must be post-open. There is a thoracotomy, must be post-procedure, and you should be able to appreciate that there is fluid on this lateral decubitus image. So as we said, you can do a thoracentesis if you have a 10 millimeter wide on the lateral decubitus. As I've indicated, it is useful for you to as much as possible do that under image guidance to reduce risk of injury to internal organs. Fluid analysis begins with gross examination. You need to get the fluid and examine it, determine whether it is pus, what is the smell, is it putrid, which would be infection, is it highly viscous? Mesotheliomas tend to be highly viscous. Is it chocolate sauce, anchovy paste kind of, which would imply amoebic lung abscess? Is it chylous, or is it just simply serous? Okay, so like what you see here on the extreme right is chylous pleural fluid. Obviously, you can appreciate this is purulent. The second from right, and then what you see here, I don't know whether you are able to see. Let me use my. So what you see, no, that's not how it should be. It's supposed to be. Yeah. Yes, so this is chylous. That is purulent. This is, you have a hemothorax. So there is blood, and this looks serous. Okay. Now it is next. So serosanguinous fluid. This is serous mixed with some blood. You want to suspect TB, malignancy, pulmonary embolism, esophageal rupture, pancreatitis. Hemothorax is defined by a PCV of the pleural fluid of at least 0.5 and above. Okay, and when you have that, then you should consider frank bleeding into the pleural cavity. So after you have grossly examined the fluid, then you need to send it to the lab for analysis. And the analysis is very systematic. So you want to send an amount of fluid to cytology and another to biochemistry, and also to microbiology. So some of the things that are done would be the cell stains to look at the cells, white cell count and differential, look at RBC, biochemistry. They will do glucose levels, total protein and albumin, LDH, amylase, pH, and lipids. We've already covered, so this is important for you to classify the fluid, okay, based on what you find from these studies. Then you would have make a decision as to whether you're dealing with a transudate, an exudate, or a mixed picture. So the commonest, one of the most common causes of pleural effusion in our setting is tuberculosis. It's usually an acute illness in about 2/3 of cases, a chronic illness in a third, usually unilateral. And about a third will have parenchymal disease, which means 2/3 will not have any evidence of parenchymal disease. The pleural fluid is exudative with a lymphocytic predominance in terms of cells. So the diagnosis is, as we have discussed in the TB class, but some of the things you need to do will be the Mantoux test. You need to have the culture, have the fluid assessed, adenosine deaminase, interferon gamma, and PCR, and biopsy. The most sensitive in terms of diagnosis is actually biopsy. So if we look at neoplastic diseases of the pleura, the commonest would be, depending on the gender, obviously, in our setup, the commonest would be breast. If you're looking at, in general, it would be lung, and then lymphomas, ovarian, stomach, and then unknown. When you have disease, pleural disease related to metastasis, the presentation is usually subacute to chronic, with presentation of a slow or insidious onset, dyspnea, cough, weight loss, chest pain, malaise, fever, chills, and in some patients it will be symptomatic. Malignant effusions are usually exudative, but rarely they can be transudative. There will be a predominance of the mononuclear cells, that's lymphocytes, macrophages, and also mesothelial cells. And up to a third will have a low pH. The diagnosis is usually by pleural fluid cytology, pleural biopsy, and thoracoscopy. Thoracoscopy, obviously, it is an invasive test, but in order of sensitivity, ability to make a diagnosis of the disease, thoracoscopy will be the highest yielding, followed by pleural effusion, pleural biopsy, and lastly, fluid cytology. How do we treat this disease? Can be done through serial thoracentesis, chest tube with pleurodesis, thoracoscopy with pleurodesis using what is called talc podorage, pleural peritoneal shunts, and also pleurodectomy. Usually, presence of a pleural effusion as a result of malignancy portends a fairly bad. Sorry, I don't know whether you can hear me with all that noise. portends a fairly bad prognosis with limited survival. So usually means by the time someone has a pleural effusion due to malignancy, it means this is really stage 4 disease. Mesothelioma, not very common in our setup because we are, so this is a condition common in areas where there's a lot of manufacturing and mining related to asbestos. It has a very long latency period from exposure to disease, 35 to 40 years. And the diagnosis is usually fairly difficult. It's usually in the context of an individual that's worked in the asbestos mining or asbestos-related industry. As you are aware, there is now a convention to ban asbestos use and also to restrict the way asbestos is mined and used from the realization of the cause of mesothelioma from asbestos. So benign mesothelioma is usually localized pleural tumors of mesenchymal origin, asymptomatic in most cases, but patients will present with cough, chest pain, dyspnea in about 40% of asymptomatic cases. You may have to, can be associated with the paraneoplastic syndromes, can also present as a solitary mass and cured by surgical removal. Pneumothorax, this is air in the pleura, can either be primary spontaneous or secondary due to, for example, cystic disease or a bulle in the lungs, or it can be due to iatrogenic, traumatic, or related to menstrual cycle. That's what is referred to catamenial pneumothorax. Primary spontaneous pneumothorax usually arise from subpleural plebs associated with smoking. Patients tend to be taller and thin. Would usually occur spontaneously in a patient at rest. The diagnosis is usually confirmed by chest X-ray. Usually recurs. Can be ipsilateral on ipsilateral side and 15% on contralateral side. The second recurrence rate of up to 50%. The treatment is by observation, supplemental oxygen, aspiration, chest tube insertion, thoracoscopy with pleural recession and pleurodesis. Especially when there is recurrent disease, but still you can have a recurrence rate of 3 to 4% after thoracoscopy. Secondary pneumothorax, as I said, are usually due to underlying lung disease such as COPD, cystic fibrosis, interstitial lung disease, or pneumocystis. The recurrence rates in secondary spontaneous pneumothorax is usually much higher than in primary spontaneous pneumothorax. Treatment is through chest tube placement or pleurodesis, especially if there's a high risk of recurrence. A Chylous pleural effusion is usually is defined as the presence of chyle, that's lymph fluid in the pleural space. The diagnosis is through thoracentesis and examination of the fluid, which looks milky. And if you do chemical analysis, it will have very high levels of triglycerides. the management is, so in terms of causes, you need to look for underlying tumors like lymphoma, trauma, for example, during surgery where there can be accidental ligation of the major lymph vessels, idiopathic or miscellaneous. Hemothorax, usually related to trauma, but can also be a complication of excessive anticoagulation and bleeding disorders. Treatment is by chest tube placement for two reasons. Number one, you want to evacuate the blood, but also you want to monitor for continuing bleeding. If there's continuing bleeding, then you may require surgical intervention to arrest the bleeding. Okay, so these are some of the complications that you can get from hemothorax. If you have retention of clotted blood in the thorax, infection, effusion, and fibrothorax, where a decortication may be necessary. Fibrothorax, the challenge with fibrothorax is that it will restrict lung re-expansion, and that's why decortication may become necessary. So that's an overview. An overview of pleural disorders. As I said, it's a very broad area. This is just an introduction. I think the most important thing is when patients will present with pleural disease, you want to, number one, confirm that yes, indeed, you have pleural disease. The commonest presentation is pleural effusion. Anytime you make a diagnosis of pleural effusion, you must look for the underlying cause. The critical, important underlying causes that we discussed are those that are related to infection, especially in our settings, and those that are related to non-infectious inflammatory conditions, especially the connective tissue diseases, and those that are related to changes in hemodynamic disturbances like in heart failure, pulmonary embolism, and obviously also those that are related to malignancy. So anytime you see a pleural effusion, you need to ask yourself, what is the likely underlying cause? We have talked about how we investigate pleural disease by imaging. The two most commonly used imaging studies, ultrasound and plain chest radiography. Then obviously ensuring that you have that fluid being removed for physical examination, and also biochemical and microbiological examination. Where malignancy is suspected, cytology is very, very important. We said outside a situation of hemodynamic disease, like heart failure and pulmonary embolism, you want to have a pleural biopsy of some kind done, because it gives you the best yield, diagnostic yield. The management, as we have indicated, is related to relieving symptoms related to pleural effusion by draining the fluid, and also providing specific therapy for the underlying condition. Okay, if you have any questions, please. I guess I have responded to that question, Adan. Treatment of pleural effusion. As I've said, the primary, what you want to look at is the patient having respiratory embarrassment due to accumulation of fluid in the pleura. If yes, then you need to drain the fluid. Obviously, pus must come out if a patient is having an empyema, however small, that pus must be drained. Otherwise, in other places, you just drain it to relieve the embarrassment, the respiratory distress, and then offer specific therapy that is related to the underlying condition. Okay, I guess that's it. We meet tomorrow for your final session, which is smoking-related lung disease, and then we make arrangements with the class rep for a couple of missed sessions in the coming week. Thank you and have a nice afternoon.
You too, doctor. Thank you.